to tolerate sounds which are much above his comfortable level.
No, see, the thing is, we say that we don't want to over amplify the electrical current. See, when we talk about the acoustic dynamic range, we have a far wide range which starts at the threshold, which is in a normal person around anywhere between 0 to 10, and the uncomfortable level comes around 110, 120. So that much a wide range, which is not so, because here we are dealing with electrical current, and you cannot have the same kind of dynamic range here. Plus, if you are giving too much of electrical current, there are chances that the current will be splashing around to the electrodes and then the signal clarity is not going to be there. So we try not to give too much of amplification, to keep it at a level where the person is comfortable. If we go on stimulating, since the other nerves are also nearby, there are chances of stimulating those nerves, and then you can get you can stimulate the facial, or you can get some facial twitching, etc., which you don't require. That is why we need to keep it within the comfort level and not go beyond. It should be loud enough for the person to be able to hear and comprehend, but you need not let it be loud, because still they will be able to hear the loud sounds, but then automatically, depending on the implant, it would be something like what an AGC was.
Can I add to that?
Yeah.
I think what she's trying to ask is that she's getting confused, like we normally say in audiometry, whatever, you have something like a most comfortable level, and then you have a loudness discomfort level, which is significantly above, and your dynamic range goes above your most comfortable. Here it's more like it's the maximum comfortable level. So what you're setting the C levels is not your most comfortable level really, it's your maximum comfort level. So you don't want to increase the stimulation above that. So it is reaching to the uppermost part of your dynamic range. And if you go above that, obviously you're getting discomfort. So you're setting it at the, and you're going to look at it as you go up, either the child is showing behavior like, for example, twitching or any kind of usual, you know what kind of behaviors children or adults show when they have a problem tolerating the sound. So you're setting the current level, you're setting the current level just below the level at which it's going to be uncomfortable. You make sure you validate that properly even in the light mode before you send the child home with that map.
See, why cochlear implant is done is to get effective auditory stimulation. What we are really aiming when we are doing mapping is, those parameters which are set, T level and C level. As she said, validate. What she means by validating is make sure that the person gets a soft speech and tolerance to the loud sound. So, post mapping, it will be addressed in the afternoon, those things what we do. But we make sure that the person is getting a percept to the whole speech spectrum, including sound test, other assessment. Make sure that you give proper access to the speech and try some soft speech also, soft voice, soft conversation, make loud noise. So this is what is the aim of the cochlear implant. They may hear when there's a loud sound, they may hear it loud, but if you have set the levels properly, it will not be uncomfortably loud. If they can make out those timing clues and envelope clues and everything they can make use of. So the soft will be perceived soft, the loud will be perceived louder but comfortable.
Yeah, and one more thing, you said that the child was not ready to wear a processor, during switch on. That is why there is a general thing in the pre-implant therapy itself. During the process, the habilitationist use a dummy implant before the surgery.
It was that the child that was not the problem. Just at that particular moment,
he didn't want
the
to wear
child
it.
didn't want to wear it. But at the end, we saw that.
No, but this thing is, I just want to emphasize that this thing is available. Dummy implant processors are available.
And the child has been.
And most of the centers are
wearing. He is very well conditioned, but though he was so well conditioned, at that particular moment he didn't want to do it. And when we got him to do it,
it's very different wearing a hearing aid, having with this and having an implant, including the body worn thing. So generally, if you give a dummy processor 10 days before, and the child comes into the session for switch on wearing that, and all you do is nonchalantly take that and put this one on. That's about it.
It doesn't happen that often. This was one particular.
Yeah, but I mean,
No, this is just a suggestion, especially for the beginners, because there's always something to learn every, update. I mean.
They had a surgery too, so many kids are very touchy. They don't want you to touch them.
Yeah, I think this thing will be covered, I think, in Neeti's lecture. So.
I had two doubts. One is regarding the impedance that you said. You said it should not be too high. So is there a particular level that, so what is that?
There are it is different. The particular levels are little different with the different implant systems, and they are shown on the test itself, where it gives the status that beyond this it is going high, so it gives an indication, and therefore you can accordingly either switch it off. If it is short, it shows on your test, that is on the results.
And the second one is regarding, if you could just elaborate on pulse width and volume. You said pulse width is changed for loudness, and then the second thing you said is also volume.
There are different ways of changing the loudness. Basically, volume works with your M levels or the C levels, where you are reducing or increasing, your M levels are set accordingly. Whereas, though your M levels are at a particular current levels, increasing the pulse width, with the same M levels you can get a louder percept by changing the pulse width.
Okay. Thank you.
What you do is, it's like you set a map, using those parameters, which are M level, T level. If needed, you change the pulse width, and then when you give a map to the person, because we are doing in our clinic, which are quiet, though we make loud sound, make sure that it's not uncomfortably set levels. But when they go out in the real world, if they feel loud, they get just some control to work on, that's volume control. Or they have got sensitivity, which she mentioned. How much distant sound you want to pick up, how much closer sound you want to pick up. So those controls are given. Those are fine-tuning kind of a thing, and pulse width is basic map. Yeah, patient can control.
Rahul.
Only two questions.
Yeah, now you can ask.
See, as you mentioned, at the first mapping, some objective tests are also done. So after each mapping, or even after that, any other test is we do, we just to, after doing a mapping,
you can do an aided, you can check the aided responses of the child in a sound-free situation to see how well across the frequency the child is responding.
but are there any speech tests is also done?
Depending at what level, if you can even do a speech discrimination for a
Shabnam, this is all going to be talked about in Geeti's lecture, so I don't think we should be talking about it. It's not fair to her, otherwise her lecture won't have any meaning. And another thing to add.
There's one question, huh?
I'd like to know.
That saves me to answer a question.
No, this lectures are going to have certain things overlapping, but obviously we are not trying to bring down as much overlap as possible.
From day one, how should be the frequency of mapping, and when do you identify that map has been stable, and how much importance do you give to format frequencies correlation for particular bandwidth of map?
The frequency of mapping varies from clinic to clinic. I can tell you what pattern we follow. Is at the initial map, that is the switch on. Generally, most of the implants, they have a provision of giving up to 3 to 4 maps. So depending on how well the child is conditioned, you know at your first mapping when next to call the child for mapping. If the child is well conditioned and you are able to obtain fairly good threshold levels or the comfort levels, you can give progressive maps wherein over a period of time the parents can use them one after the other over a period of time. So anywhere, or if you find that on the first stimulation itself the child has not responded well, you may call the child the next day or day after again. But most of our children who are well conditioned, they require after the initial map about maximum a week to 2 weeks time for the next mapping. And actually every mapping you can decide when next to call. Initially it is at least once in a month in the first year. And once you get a stable, comfortable, when you are sure that the thresholds are well established, you are not finding much variation in the threshold at different channels, your aided graph looks well within the 30 dB range, then once in 3 months, then once in 6 months, and then once in a year, and so forth. But mapping at least once in a year after say 2 years of implant use has to be done, because as I told, it's not only setting the parameters but it's also a diagnostic tool.
About the format?
About the format, that depends. See, when you're doing your follow-up mappings, as I had mentioned, that you have to have a feedback from your therapist, the parents about what sounds the child is able to pick up, what they're responding to. On that basis, it can be formed. And I think Ms. Aziza Tayebji has formed some grade which can be used to determine that. I don't know much details. I think Fatima can give better information about
that. I think Fatima, just one thing I'd like to tell, that initially when you're setting a map, the first thing, it's a very conservative map only for the child to take in that information, to be comfortable. And every clinic has a different procedure, but I think you should call them at least weekly for a first month, and then maybe 15 days, and then you yourself come to know how soon the map is, fixed or set. So, Fatima, do you want to say anything before?
I just wanted to add that in the mapping protocol, that earlier even we used to not map the child till 6 months, once the map is stable. But of late we have been finding that when we call the children later on, their T's and C's really go haywire. So now we have made it a rule, at least every 3 months children are mapped.
Yeah. Okay, we can split for lunch now, but just make sure you're here. I'll say 20 minutes, but I'll stretch that to half an hour.
Okay, one more announcement. The surgeons who are going for the dissection, one of the residents will accompany each batch. So,
Intervention Center in Mumbai that works with hearing impaired infants and babies below 18 months of age. Topic for our discussion today is importance of counseling in setting it.
That is the second one.
Oh, sorry.
I'd ask you to switch.
Okay, sorry. Assessment of progress.
Yes.
Please go ahead.
Is there any way that I can ask all of you to come in the front, because it's the most non-threatening topic?
I think
no questions will be asked.
Everybody, please come in front. Everybody come in front. Don't leave empty spaces in.
I thought they didn't actually want me to present. Okay, I think it's not like that. I have no notes. This is a topic that is I would say extremely important, because it makes us reflect upon ourselves, because it actually shows how we are functioning and what the services that we are offering, are they effective enough or not. So generally when we are talking to each other about our children, one, we do so with using their name, which is absolutely unethical. The second thing is that we use comments like, oh, my child is fine, oh, she's doing pretty well considering whatever. So these are the kind of comments that we make to talk about how the child is progressing or how the child is doing. However, I find that to be unacceptable, because one, first of all, we need to think about it, that do we think an evaluation of progress is necessary? Secondly, is it done periodically at regular schools for children with normal hearing? Most of us have got children who go to regular school where we pay a fee. At our center also the children pay a fee. So would it be okay if our children who go to regular schools for children with normal hearing, if they were to just have comments by the teacher at the end of the year saying, yeah, your child is good, oh, she's okay. No, that wouldn't be acceptable. Do we have an evaluation if we have an illness and are undergoing treatment? When the doctor checks your blood test, does all of those tests, you want to know something that is quantifiable. And this is my pet. Is it done even if you are on a weight loss or a gain program? The answer to all of this is yes. So if I go to a weight loss program and I pay my money, and then the person says, can't tell me how many inches I've lost or how many kilos I've lost, that won't be acceptable. So it becomes even more crucial for children who have got hearing loss, for us to be giving them quantifiable assessments. So the answer to all of these is yes. So what do we mean by assessment of progress? It should be objective, it should be quantifiable and measurable. It must be done at regular intervals. It must be factual, not based on personal feelings or biases. You know, we have to try so hard because we are working with a child and then we say, no, she is progressing. Why? Because it's a reflection of ourselves. And we don't want to show ourselves bad at any time, and we're all humans and we're all humans with egos. It should be observable, both to the parent as well as to us. The tools that are used for assessment must be age appropriate. They must compare children with a hearing loss to those who have normal hearing, because that's the only thing that you can see that how far behind or how at par or are the average or below average in comparison to normal hearing children. And the most important, which you might think is stupid, is that you must see progress between each assessment. So how do assessments help us, and why do we need to have the assessments? Well, they help us develop goals. They help us to set realistic expectations, both for ourselves, of the child and the family, and of the family of the child, the family from the child. It helps us to identify potential problems. You know, we all know that children with a hearing loss generally don't have only a hearing impairment. They have other additional challenges that show up only later as they grow up. So that is something that if we start seeing these kind of patterns coming in, we must raise the antenna that okay, there is something else that is going on, and refer for an evaluation. It demonstrates the effectiveness of the audiological and communication intervention. So how well suited is this program to the child? Is this program delivering what it should to the child, and is the child suited to the program? It demonstrates the communication mode. Now we are all very big on auditory verbal currently, very big on auditory verbal. But auditory verbal also requires the amplification system to be working. Whether it's a hearing aid or a cochlear implant, it requires that to be working. So whether the communication mode, if you use auditory verbal and the child has got a corner audiogram and has got only hearing aids, never mind whether they are analog or digital. If the child has no hearing, measurable hearing beyond 1 kilohertz, no hearing aid is going to do anything for the child which will bring it up enough into the access area for speech. And so you can try all you want with auditory verbal and it may not work. So if you have to send the child on for other methodologies, so this question is not about methodologies. My methodology is better than yours. There's nothing like that. It is something that is suited to the child so the child is able to communicate. We are all in this business for communication. So what are the prerequisites for assessing progress? We as professionals have to have a knowledge base for us to be able to know, okay, what do we check? So first of all, we need to have a knowledge of developmental milestones. This is with regards to audiology. Especially, but even for habilitation, and I will be giving those later. Motor skills of the child. For example, if you are doing a BOA or a VRA, the child may be 6 months old, but if the child has no head control and is just lying, you can't expect the child to turn his head and look at the light. If the child is 1.5 years old and motorically is not age appropriate, you cannot have it whereby the child will be able to put a cup down. Yeah. So you need to know about the motor skills. What are the milestones in audition? What are the kind of responses that you expect from a child based on chronological age and from the hearing age? What are the cognitive and social emotional skills? You need to make sure that is the child plain and simple a hearing impaired child, or does the child have additional needs? We also need to know about the possibilities and the limitations of the various amplification systems with respect to each child. So what are the factors affecting progress? Now these are, some of them are common factors and some of which I have added on. The etiology of the medical history. I can't underestimate how important the medical history of the child is for us to be able to find out or to have some idea in our head, leave alone the parents' heads, and what we convey as information to the parents. But we need to know what is the etiology. So case history is an absolute must. The length of deafness, when has the child actually come to you? Age at intervention, and after the child came to you, how is it in terms of the diagnosis, in terms of the intervention after that? Because sometimes parents aren't really ready. They have just had a shock that the child has got a hearing loss, and here we are talking about clinically this needs to be done. So parent has to be ready. So part of it is affected by that. The efficacy of intervention. Say if the child is transferred from another center, what was the intervention like at that center, or what is the intervention happening at your center itself? Again, the cognitive, social, emotional skills of the child. Does the child have additional challenges? And interaction with other families at the center. How has their interaction been with them? And what is the family motivation and commitment to follow up? So we can bang our heads as much as we want, but the truth is it's the parents who are the primary caregivers. We see the child for maybe 1 hour, 2 hours, 3 hours a week, but the child is with the parents 24/7. So it's a question of our guidance that will help them to cope at home. And what is the information sharing with parents to allow them to be equal partners in progress? And I really mean this, that the parents have to be equal partners in progress. Gone are the days when we had centers where they used to tell the parent, "Acha, abhi apne bacche ko lekar aaye na, abhi aap bahar baitho." That should not be happening. Whether it is mapping, whether it is hearing aid assessment, whether it is unaided evaluation, whether it is a therapy, a parent has every right to information to be there. It's their child. Audiology, now we're talking about dividing assessment of progress in terms of audiology and in terms of habilitation.
Hello.
So first of all, again I stress that etiology is crucial. Why? Because first when we are testing the child with a battery of tests that we went over yesterday with Deepa, all the battery of tests, including a behavioral assessment. Our center has children below 18 months, so we are really big on behavioral assessment. And we strongly believe in it. And you need to find out what is the type and the degree of hearing loss in years separately. Now we have to also realize why etiology is important is because when a child has either had hypobilirubinemia or is a rubella baby, there are chances of the child or has had birth asphyxia, there are chances that the child's hearing will improve. So you can't once and for all just fit a hearing aid and then say, okay, now it's done and now you go on for therapy. And after a few months, say you find that the child starts taking off the hearing aids. It has to ring a bell in your head that maybe the hearing levels have changed. So, and what I have put down there, which is very important, is that you need to know the information about both ears separately. At our center, we follow that for children below 1 year of age, we check them out every 4 to 6 weeks audiologically. Yeah, so unaided is done every 4 to 6 weeks for children below 1 year of age. For 1 to 3 year olds, at least every 3 months, and for 3 plus children, we do it every 4 to 6 months unless otherwise necessary. For example, the child in this video who is there, he was 5 months when he came to us, and we've noticed a significant change, and I presented on this child at CG in Pune. We noticed a significant change going from profound to a moderately severe. He's a rubella baby, and this is at 5 months. He's using ear inserts, which are, I can say, God send or my director's send. So. Should open now. And you won't be able to hear the sound because double click केला है.
Play from outside. Minimize the PowerPoint and play from outside. I'll be for
the videos with the clips make sense. Showing the clips at the end doesn't really make any sense.
Hi, Priya. Katam.
Australia England better than America moving the lane. Australia England and Toshas.
Okay, so what we were talking about was, and all this is done using ear inserts or pediatric headphones. I've had ear inserts for the last about 4 years. Before that, I've been functioning using headphones with a towel on the head. But it does work. It takes longer, but it does work. So it's really well worth the effort because then you get better hearing aid fitting. So the first part is getting an unaided. What is the child's hearing? And please understand that when we are fitting digital hearing aids that we so harp about, The point is that we are feeding into the computer, to the software, fitting software, incorrect audiograms, and time is lost. So the first thing is amplification. Amplification can be in the form of hearing aids or in the form of cochlear implants. The first thing is the fitting. So on what are you basing your fitting? Are you basing it on the bearer? I hope not. Are you basing it on the ASSR alone? I hope not. Next thing after that is consistent all day everyday usage of well functioning hearing aids. We do not tell the parents कि वो जितना देर आज पहनता है ना पहनने दो, फिर कल थोड़ा और टाइम, फिर कल थोड़ा और टाइम. Hearing, if you are looking at picking up speech and language via hearing, it's an all day everyday process. So the child has to wear the hearing aids all day every day with well functioning batteries, with not broken cords if you are looking at body worn. At our center we are fitting only BTE hearing aids. And then the validation of these, which we'll go into later, and reprogramming. The reprogramming is to be done especially for children below 5-6 years of age, because to adjust for their canal volume size. And the second thing is if you notice any changes in their auditory, in their hearing levels. With the cochlear implant, you have appropriate mapping via conditioning, and you can see a progress in that also, assessment of progress that okay, initially was it just behavioral observation, then did it move on to VRA, and thirdly did it go on to conditioned play audiometry. So is the child progressing as you would like the child to progress? That is something that you have to have in mind. Consistent usage again, all day, every day. Validation of that and mapping at regular intervals as Shabnam spoke in her presentation. Now how do you do the validation of auditory access? What is the child benefiting with the hearing aid versus without the hearing aid? What is he able to do? For that we need to be able to think, why are we fitting the hearing aids? Are we fitting it just because it's on paper? For a cochlear implant they have told us that we cannot fit on implant without hearing aids, so chal kuch bhi laga do? Or is it really that we want something for the child to achieve? Because the pre-implant period time is extremely important. So we use other functional measures, like somebody had asked and we were talking about doing an aided audiogram. Now an aided audiogram does not tell you how a child perceives speech and language. It tells you where the child is, but it does not tell you how the child perceives speech and language. So the next, the other thing that we begin with is environmental sounds. Sounds outside the home, sounds inside the home, just to draw an awareness, to build up a listening attitude in the child. And they begin with loud sounds going on to softer and softer sounds. And what we do with our parents is that for every maybe 20 sounds that we give them around the house, we tell them come back to me with 5 more. So that way I keep adding to my list of softer and softer sounds and home sounds that are typical to everybody's home. The pitch or the maze, the pitch is parental evaluation of a child's auditory skills, and that relates to how the child is using hearing aids or any amplification device, as well as the maze. That is the meaningful auditory integration scale. I think that was covered in yesterday's presentation. The Link 6 sound test, we move from detection to identification or imitation of those sounds. I can't stress how much of information we get. And I hope that we don't hear ourselves as audiologists saying, oh, the child can't hear the show and the so doesn't mean you implant the child. Like hell you do, if everything else is okay. So after thorough evaluation, but if the child is not getting the show and the so, and that is something that you can do using toys. You have also the MacArthur Communicative Inventory Scale, which kind of tells you how the child's vocabulary is developing. And I also use it for picking up on what are the speech errors that the child has. See, initially we don't talk about speech training, because if the child just starts talking, it's like us. If I'm learning a new language and if you keep correcting my pronunciation just the moment I open my mouth, I'll say to hell, I don't want to learn that language. Because every time I open my mouth, you're there to correct me. It's the same with the child. So if the child has just started talking in 2-word or 3-word phrases and you keep saying, उसने प बराबर नहीं बोला, उसने ब बराबर नहीं बोला, बोला पापा, the child will even stop doing whatever little that the child was doing. So please, the speech corrections come in later. I'm bothered about language. We're talking about communication. We're not talking about imitating parrots. We have the CAP scale, which is the categories of auditory performance going on. I don't think that I have the time to go into detail considering my video is not showing up. So I hope you'll be generous and give me 2 more minutes. And of course the parent and the habilitationist reports. And I put the parent down first because the habilitationist or the audiologist sees the child less frequently than what the parent sees. So you have to build up on their confidence to be able to give you accurate information from what goes on at home. Don't tell me I have to do that again. Try once and then otherwise. Try once. I can't see myself anymore. How do I go on to minimize this? One second. These are real videos, not edited or anything. So this child has been really having a field day. He is there in this video as well as the next video, and I have no clue what his kanka. He goes around saying I have no clue what that is. But in between my chatter, in this clip, you can see him imitating the and the e. And he heard me at that, and so he started putting the video.
Thank you.
Did you hear the He's 1 year 9 months old at this time.
No. Thank you. Yeah, you have to put it in.
చాలా ఓపికగా ఉంది చేయాలంటే.
He's 1 year 9 months old in this video.
అదే మరి స్పీచ్ థెరపిస్ట్.
Okay, then we go on to speech perception. This again, he was having a field day and he was 9 for everything. So the first thing that we begin is the learning to listen sounds, and I think those of you who are following auditory verbal techniques do know about what the learning to listen sounds are. Now all this, what you see is not part of therapy, is part of audiology. So please don't do this as part of therapy. Picking up cards, life is not about picking up cards. Life is about communicating, interacting with each other. So then it goes on to item selection by the name, that means not by the sound. Commands vary in complexity, the body parts, because those are things that children learn first. So we have it in Marathi. This is something that we have come up with. So it's like port, board, oat, things like that, and popper, doper. And in English we have things like teeth, feet, cheeks, legs, neck. We have nose, toes. So all these kind of things that you come to know, and you use this with hearing aids first to see what mistakes is the child making and can we do anything to correct it, and then think about an implant. So I'm talking about pre-implant assessment also is as crucial as post-implant assessment. Verbs as is over here, and we have this in English and in Marathi. So it's like ek mulgi khate versus gate, radto versus charto, and in English we may have things like riding, writing, slipping, sleeping, those kind of things that we have. So this is with him doing that, and I'm not going to attempt it by this. I think we'll go back to. The first one is yuck, because that's a picture of a boy spitting.
You mama, the boy is spitting. You mama. Give it to mama. Quickly. Which one is that? Sit properly, everybody. You want to fall now. Thank you. Athar is going to fall now. Be careful. Bring it down. Give it to mama. Not that one. I want the boy who's spitting. Give it. Yeah! One is eating her food. Give it to mama. Give it. Give it to mama. Quickly. Thank you.
అర్థమైంది ఆపరేషన్ పరపర
Then we go on first to our favorite, the speech. So at our center we follow the Link's phonetic level evaluation, which we take out from the child's utterances and we put on and see in which words is he producing in the initial, medial, final position. It's not something that I make my children do. Then we go on to, from the phonetic we go on to phonologic. And the main thing that we have to understand is that there are ages and stages for the child to pick up certain speech sounds. There's the vowels or the consonants. A child who is 1.5 may not be producing the sh or the sa. He may be producing it as a tha. But that's fine. So we need to be aware about what is the speech acquisition scale. And I think this is a little light, but here it gives you all of these consonants and what are the ages at which age ranges, averages. And these are for normal hearing children, at what they pick up, at what age they pick up these. So that's very important for us to keep in mind, because something that is very nice is that parents start getting when they come to the center they think if my child hears a little bit it's okay. When the child starts hearing and the child, then they say, oh, when will my child talk? When the child starts talking, they say, oh, but when will he talk clearly? So this is the kind of expectation that parents show, and so it's very important that you need to tell them that have realistic expectations. In terms of rehabilitation, our goal should be 12 months progress in 12 months time. So it's not something that you can keep going on and on and on, and the child remains at your center for years and years and years at the same level. So for that, we again need to know, because these are the areas that we work in: audition, speech, language, cognition, social emotional skills, and communication. Assessment is an ongoing process, whether it's audiological or rehabilitational. It is an ongoing process, and each session is diagnostic. So the next session is based on the plan of the previous session. Here, the director was doing something with this child as in a negative. As you can see in the plan over here, to understand the negative example, it's not sharp, it's not on, it's not ready. So the mom has actually got a real knife, and Shafali has got a toy knife, and it's as not sharp. I don't think I would have the time. So it's basically when the child nods his head and says sharp. So he's indicating that not sharp by shaking his head for the nod and then the sharp. Here this is about assessment of progress. So here you discuss with the parents very, very openly, because it's a parent-professional partnership. We are not God. So we have to get the parents to see where the child is, and for them to give us feedback that where do you think the child is. We don't give them all the information and say this is how you have to do. And you have to guide them regarding where the child's current level of comprehension is. At our center, we plan for 90 days because parents can't really look, and we also can't guarantee anything, besides the 90-day plan. So we have a 90-day plan in audiology as well as rehabilitation. And at the end of 90 days, we evaluate whether the child exceeded the plan or didn't do as planned, and the reasons for both. And then the next 90-day plan is set with the parents. So this is Shefali in conversation with two of the parents. The other formal assessments which are as highlighted over here in pink is for hearing children, and that's what we use for our children, whether they are hearing aided or cochlear implanted. This is an ongoing assessment which talks about audition, language, cognition, communication. We have the Rossetti Infant Audio Scale. Believe you me, these tests cost a bomb. But it's a question of whether you want to do it. I'm sorry, this is all video, but I don't have the time. You have the rapid basic concept scale. The conclusion is that you must ask parents to ask questions about their child's progress. They need to be empowered, and they need to know what is going on in their child's life. You must give them complete information through various resources. So if you can't get the information, tell them I'll get back to you. Deafness is not about hearing, it's about communication. It's about people, it's about interaction. It's not about methodology, but about communication. And periodic and appropriate assessment prevents stagnation. I mean, how can we go to sleep night after night if the child has remained at the same level for 2 years and 3 years of their life at your center, or wherever the child is, and miss diagnosis? So it's extremely important to have an assessment of progress. Thank you. I'm sorry if I sounded aggressive, but this is something that I really feel for.
Giti, you can play a couple of videos in the program. Which way you feel? No, we'll manage.
Is Dr. Udani here?
Not as yet.
He hasn't come, so maybe you can play a couple and show if you want to. Does it make sense with that? Okay, fine.
Note dialogue is dialogue is important.
Like.